Good morning to you all, and welcome to the 10th lecture of the 2020 Palliative Care Lecture Series. Hospice New Zealand would like to thank and acknowledge Cancer Research Trust New Zealand for their generous support and funding to deliver these free lectures. The lecture today will be recorded, and it will be available on the Hospice New Zealand website. Please be aware there will be an opportunity for questions at the end of the presentation. We would now like to introduce our guest speaker today, Dr. Janet Turnbull. Welcome, Janet. Please go ahead.
Right. G'day, everyone. Just like to make a couple of comments with the first slide. I have realised that my last-minute editing left a couple of typos, so there's a couple of spelling mistakes, so hopefully you will allow those to go ahead. And I also wanted to acknowledge a colleague of mine who emailed me yesterday, Kate Gallatley, who is a bit of a titan of palliative care and aged care in the southern half of the South Island, who I worked with for a number of years and learned a lot from, particularly about the approach to some of the problems that we're going to discuss today. The presentation will be reasonably quick, and I want to leave a fair bit of time at the end, hopefully, for a lot of comments. The issues that I really wish to discuss in relation to palliative care and neurodegenerative disease is the question that I was asked to follow through: what role does palliative care have in neurodegenerative disease? And I've extended that to, what is the point at which specialist palliative care services, i.e. hospice or hospital palliative care services, are involved in patients with neurodegenerative disease. We're going to focus on case studies to illuminate some of these points and hopefully provoke discussion and comments. So we're going to do a couple of case studies on dementia, and in this particular case there are two people with Alzheimer's disease. I'm going to have one presentation on a patient with motor neurone disease and talk a little bit about the Parkinsonian disorders in relation to palliative care. There are obviously a lot of interventions of interest that we can talk about, and I will touch on those, and maybe if people want to talk about them at the end of the talk, that would be what I would be keen to discuss. There is a reasonable focus on end-of-life care, by which I don't mean to intend that's the only contribution that palliative care has to the management of patients, but it is a really important issue. Mainly because it can be very challenging, can be unpredictable, and there needs to be a lot of support because many of these patients do die in places that are unfamiliar with the problems that they have. And the last bit is, how do we do it in Wellington? Well, a lot of the cases actually come from Wellington. It's not to actually say that we do it perfectly here. Far from it. It's just where the cases came from. And we do have a system of managing people which is probably suburban and city-based rather than rurally, and we have a focus on community care. But that is not the perfect system by any means. And what I wanted to get people talking about, as I think about a lot, is how the systems support care and how we work together as health professionals. So, as I said, all of the cases that I'm going to talk about come from the combined community teams providing care in the Wellington area, which is basically CCDHB as it's constituted, and most of you will know that as the city, the hinterland of Pororua and Kapiti. Everybody in the community and all of the inpatient palliative care teams have been involved in these patients in some way, shape or form. So I just really wanted to acknowledge Mary Potter Hospice, both the inpatient and the community teams, the hospital palliative care team, what we call the older adult service, which I largely work in, which is associated with psychogeriatric service. We have very strong relationships with the Parkinson's Society, the MND Association and their field workers, plus Dementia Wellington. And I like to emphasise that the success of managing and supporting patients and their families really comes from coordinated and informed care. And the real tool that makes a huge difference to all of these patients is, in fact, the MDT team. This is one I've dragged off the internet, and it focuses on patients with motor neuron disease. And like all good slides, it's got the people in the middle. And as you can see, there are at least 6 allied health professionals. But in fact, there are many more, and we will enlarge on that with each patient. So fundamentally, patients with motor neuron disease, and to some extent Parkinson's disease, and in some instances patients with dementia who have communication problems will need these people. The other people I'd like to add in, if we were able to, would be the social workers and the specialist nursing and medical staff. So the multidisciplinary team is critical in the management of all patients with neurodegenerative disease. The real function for all of these patients is important that they are involved from the beginning, right from diagnosis through to advice and support and managing problems all the way, which does improve quality of life. So the management of these types of patients is crucial and does need to be coordinated. So if we could move to the next slide. So there are certain themes that come through because there's a huge multiplicity of syndromes and causes for the problems. The major theme is the length of the illness. Patients with Parkinson's disease often live for a very long period of time, and there's a great need for continuity of care. It's striking that there is an almost total lack of disease-modifying treatments in all syndromes, with dementia, Parkinson's disease and motor neuron disease. It doesn't mean that people aren't trying from the perspective of research, which we can touch on a little bit later, but all treatments are in fact symptom-modifying treatments, and this includes cognitive enhancers, it includes levodopa for patients with Parkinson's disease, and the various forms of delivery and DBS. So, in a sense, the first question is, does that mean that all care is palliative? In some sense, I think it is important to not emphasise this issue, but to raise it as an important factor. There are a large number of interventions that will modify symptoms, and like with many of these types of problems, particularly with motor neuron disease and some forms of dementia and early Parkinson's, there's a great difficulty in diagnosis, and so patients do start off on the back foot in getting support. And then that can complicate some of our ongoing programs because there is a difficulty in living with the prognosis versus living with the illness. This is particularly true, I find, when patients with motor neuron disease who often get told their prognosis, well, they used to be, still happens sometimes within the first half an hour of being diagnosed, and that's a real issue because I think living with the illness is a skill that we need to encourage them to practice because it allows good quality of life. As with most things, community care and trying to avoid hospital admissions where necessary and trying to provide care in in appropriately managed institutions if institutional care is required, and we'll talk a little bit about that because it does help with care planning. This is my favourite photo from the last couple of years. This is a picture from a wealthy medical organisation in Britain that owns a copy of the first edition of the essay on the shaking palsy, which was published in 1817. Essentially, the basic description of Parkinson's disease was done then. It has been largely modified and codified, and there are now many different syndromes associated with Parkinson's disease. But in many ways, we still observe and plan and manage and support patients through. So things don't always change that much in 200 years. And it's a very good book if anybody wants to read it, and if anybody wants to read about James Parkinson, he was an amazing man. So we'll move on to the first case. I'm going to start to talk a little bit about patients with dementia. This is a chap that I worked with this year who had a dementia. He's had a diagnosis of Alzheimer's and had a relatively rapid deterioration. His diagnosis was only made about 3 years prior to his death, which occurred this year. He was in his early 70s. He was divorced, and he'd worked as a businessman all his life, and he'd been a rugby player, a forward. And he's a big, tall man. He lived in his own house in Kapiti, and he had some paid carer support, and he was living alone. His family lived across the road from him, and this was his daughter who was working full-time and his 2 children. And the older adult service was asked to review him regarding capacity for him to make a decision about a total hip joint replacement. He had significant osteoarthritis and was limping a fair bit. The initial assessment that I made was that he lacked capacity and was a very high risk for an operation. The real risk was, although he was very fit and healthy, he was really unable to hold a conversation. He had no memory. His comments were inappropriate, and he would not have been able to comply with any rehabilitation procedure, and would be at high risk for ongoing dislocation. And he was still walking. He had difficulty going up and down steps. So this was a critical issue in changing the focus of his care to oversight. So he got 12 hours a day oversight, largely paid for by himself. We have invoked the EPOA so that family could formally take over the finances, and that worked well for a number of months. He was able to travel up to his favourite surfing beach. He was being prepared to go into care because his behaviour was somewhat intrusive. He would walk over to his daughter's house often at different times of the night and day, and it was very frightening for the children. He was unable to use a cognitive enhancer because of conduction difficulties. He probably had a small myocardial infarction and really didn't need any other medication. And once he was settled with a regular care regime, which was supported by funding by himself, the DHB and Dementia Wellington, he actually settled down. But one of the big focuses that happened this year, which has affected a number of our patients, is that COVID occurred. And it was very clear that he was not going to be able to be managed in his own home. He was then admitted to a psychogeriatric unit, and evaluated as to whether he could manage in rest home or dementia or hospital level care, and these terms may or may not be familiar to all of you, but dementia level care is obviously care for people who are relatively fit and able but in a safe environment, with people having a locked door but also increased one-to-one care. He spent some time in the psychogeriatric unit and was placed in dementia level care, but this was unsustainable. He's a very big man. He was very restless, very irritable. He was up all times of the day and night, whereas he'd been quite settled in the psychogeriatric unit. He was not physically aggressive, but very intrusive, going into people's rooms, standing over them, asking lots of questions, rambling, and at times incoherent. And he was quite intimidating. So he was readmitted to the psychogeriatric unit, where he's an inpatient unit, effectively until he died. Almost immediately on transfer back to the psychogeriatric unit, which is a specialist unit run by psychogeriatricians. It's got very good specialist nursing staff, people who are used to managing patients with dementia. He had deteriorated while in the dementia unit, but this continued. His mobility deteriorated, and because of his cognitive impairment, he's unable to use an aid. He began losing weight. He had a very poor oral intake. Sometimes he was too confused to be able to eat or be fed, and he appeared to be developing a delirium. He was hallucinating for the first time. He was unable to attend or follow any form of instruction, even simple ones. It was felt that he probably had one or two aspiration events. The medical cover in the ward was limited to a very good psychogeriatrician, a house surgeon, and the geriatrician providing support. So it was felt that he was entering the last phase of his illness. There was ongoing family discussions which were pretty clear that the family was aware that he was starting to die. So in this situation it was challenging, but there was clear coordinated agreement that there was no conflict about the goals of care, which were supportive. It was felt that he was quite sore. The traditional means or tables to try and figure out whether he was sore from a dementia point of view was quite difficult, because he would suddenly get up and walk and then stop. He wasn't able to indicate that he was in pain from his hip. But using analgesics in the traditional fashion was quite successful in helping him manage. And there was a slow withdrawal of the antipsychotic medication, which had been used. He had been on a combination of benzodiazepine medication and antipsychotics, which was quetiapine and at times risperidone. These seemed to help with what was termed the sundowning effect in the afternoon. So he eventually died. It took a month when he was largely bedbound. He wasn't able to eat or drink. It occurred in the middle of the level 4 and the level 3 lockdown, so visiting was quite difficult. Luckily, when level 2 arrived, there was some means by which his friends could visit him. The pain management was complicated. It was difficult for some of the nursing staff who had limited experience in managing pain, but were clearly able by the end of his journey to identify pain or distress. There had been concerns early on as to whether he would survive this, and the issue of transition or further transition into care took a while to resolve. There is a major degree of uncertainty for families in this situation, because in acute environments or subacute environments such as hospital units or hospices. Patients cannot always remain long-term, and one of the things that helps patients manage is good continuity of care. And this is a huge issue for many families, and I'm sure that could be lots of comments about that. But I also wanted to acknowledge the issue of COVID. This rushed a lot of the assessments for this man. It provoked his entry into care, which may have been delayed by a number of months, and one could speculate that the alteration in his routine and environment and the changing nature of his care hastened his deterioration. Because he had a rapidly progressive disorder, this dislocation was something he was unable to cope with. And this does happen. So people who go into care often die more rapidly than if he'd been able to manage at home. But then there is the issue of burden on caregivers. This recurs another man who I, in fact, helped diagnose his dementia some 4 years ago. He's a retired academic, a supremely intelligent man. He'd probably been cognitively impaired for some years, but clearly was demented when I saw him back in about 2016. He developed ongoing restlessness in the last couple of years with intermittently quite aggressive behaviour towards his family. He'd been a hard worker all of his life and had worked, and his wife had brought the family up, and he was intermittently aggressive towards her. He had a degree of osteoarthritis and frequent falls occurred, and his wife was really unable to manage. And he was placed both in hospital-level care and dementia-level care. Both of these failed in the sense that they were unable to provide care to maintain his safety because he was walking and falling, and he was also aggressive towards staff. So he was moved into the psychogeriatric unit and eventually died there. But the major problem for this family was that they had a huge conflict regarding his prognosis. Some of his children were very angry at the professional care because there were episodes of sedation when he became distressed. And also it was very difficult to reconcile their expectations with managing him. And this resulted in very long and challenging family meetings, and it was quite difficult to support both the staff and them to arrive at a common goal. Eventually that second patient died relatively rapidly, and there was a successful family meeting when it was clear that he was dying, but a huge amount of work was done, and it would have been challenging in any other environment other than the psychogeriatric unit. He was unable to settle in any other way. And the beauty of that particular place was that they had supportive and not endless staff, but probably considerably more than one would see in a normal hospital-level care facility. So when we're talking about dementia and palliative care, we are in fact looking at a multiplicity of professional carers, the need for institutional care, which often is very rapid, and tertiary palliative care services often advise very expertly on end-of-life care. But it is important to remember that there's a great need for input from geriatric and psychogeriatric services and primary care throughout the length of the illness. Dementia services like Dementia Wellington, which is an offshoot of Dementia New Zealand, provide long-term education and which helps relieve caregiver burden. And there is a great need for advanced care planning right from the get-go. All of these are real palliative care initiatives, but don't necessarily need tertiary palliative care services. We're just going to move on to the Parkinsonian syndromes. I'm going to do a couple of case presentations of people with very rapidly progressive syndromes. One is a man with progressive supranuclear palsy, and the other is a chap with Lewy body dementia. I'm not going to talk a lot about the more sophisticated interventions, but we'll focus on the advanced care problems. But it is important, I think, to acknowledge that for many patients, they have a normal life expectancy, but considerable disability. And that is what the real issue in many patients, and the utility of palliative care support services to other aged care services and primary care is where the nuts of the core work is. This is a graphic of all of the types of problems that you can find in Parkinson's disease. Certainly the cognitive problems with apathy, dementia, anxiety, depression, mild cognitive impairment, memory problems, the physical issues with tremor, bradykinesia, stiffness and rigidity, dystonia, constipation, as always a big issue, freezing. So there's literally tens of symptoms that it is important to balance out throughout that. And medication does help with some of these. But we'll move to our next patient. This is a man with progressive supranuclear palsy who I worked with. We diagnosed his condition in 2018. He'd had a year of problems and had seen neurologists and was quite anxious. They'd diagnosed Parkinson's disease and started him on Matapar, which is a form of levodopa, which wasn't really very helpful for him and caused quite marked confusion and hallucinations. I saw him a short time after that, and it was clear that he had the stigmata of progressive supranuclear palsy, had the eye signs with problems with his eye gaze. He had a ptosis, drooping of his eyelids. He was dysarthric, and he had marked postural instability. Within a month of me seeing him, he'd fallen and fractured his ribs. He was a very intelligent man, and he made his partner promise that he would never go into care. And this was a really big issue for her and everybody else who was involved. He was absolutely committed to remaining at home. So to provide the care, because he very rapidly deteriorated, he was referred to the Parkinson's Society and the educator, who provided a huge amount of support. He had the nurse practitioner with the older adult services. He had regular reviews by lots of district nurses. He had the community hospice team involved. Fortunately, his GP didn't do home visits, but did provide scripts because he couldn't visit them. But he had a relentless 18-month deterioration with his mobility. He developed a really nasty torticollis and really reduced oral intake and had dramatic weight loss over this time. There were major problems with continence because he couldn't get to the toilet. He had huge issues with constipation because he couldn't maintain an oral intake and was managed but required a lot of input. He was unable to speak, but was initially able to gesture, thumbs up or thumbs down. The assistive communication technology that we use in motor neuron disease, he really didn't wish to use and persisted in trying to speak or gesture. He was very clear that he didn't want any form of life-prolonging intervention. And his life was challenging. He lived in rented accommodation and moved within 6 months of dying to quite a small flat. It was difficult to get the equipment in, which was available, but getting him to accept it was challenging. He was in some discomfort. His partner was very, very stressed, throughout this time, again accepting not a lot of help, but in the end wished to manage things herself and had challenging relationships with the caregivers and dismissed a few of them, like happens in many situations. And in the end, using a pump was relatively successful. We didn't need to use a lot of medication. We did use morphine and low-dose midazolam. Again, it was difficult to assess whether he had ongoing problems with hallucinations and distress, but he was able to squeeze hands right towards the end. This was a relatively short prognosis of PSB. It is one of the perhaps more malignant problems with Parkinsonian syndromes. He's lived less than 2 years from diagnosis. It can be associated with cognitive change, although not particularly in this case. It also has a lot of behavioural change, and there are problems with frontotemporal dementias, which do require at times some psychogeriatric and geriatric support. And as you can see, it is a hugely complex disorder with multiple teams involved. We did coordinate it with a monthly team meeting for patients with the Parkinson's disease educator as well. We did do a lot of early planning and goal setting for him and his partner. Many of these patients do end up in institutional care, which is obviously avoided in this case, but it does occur and is very challenging because it sometimes occurs precipitantly. And as always with patients with challenging communication issues and sometimes cognitive impairment, there's a great need for support for aged care facilities who often do not understand or have difficulty in providing care right from the get-go when patients arrive. I just want to touch on this issue with the next patient if we move to the next slide. This is a chap who, again, I know relatively well. He's a man with Parkinsonism and cognitive impairment. He originally came from Newcastle, which is actually important in the story. Worked as a carpet layer, had his own business, hard worker. He has long-standing back pain and had been on some analgesia for this. Relatively early on in his illness, he developed marked hallucinations, which were often quite frightening. There were sometimes dogs attacking his throat and very marked challenging hallucinations, and his sleep was very poor. He was up and down, not incontinent. He'd been on levodopa, which had improved his mobility somewhat. He was slow and somewhat bradykinetic, but he was quite anxious and not sleeping. Again, COVID hit earlier on this year. His wife was unwell, and he'd become more anxious and agitated. We'd started to reduce his medication, which was levodopa. We'd introduced a cognitive enhancer, which is now recommended in these patients with Parkinsonian dementia to help reduce the need for antipsychotics later on. And he was on donepezil. He ended up in, next slide, thank you, he ended up eventually in hospital level care following an admission to a geriatric unit. He settled quite well in the inpatient unit in the geriatric services, but as soon as being transferred to hospital level care became intrusive and agitated. He was rude and swearing at times and quite frightening towards the staff, which is a challenge. He's a very slight man, very thin and normally very pleasant. He was then transferred to dementia level care where he immediately settled. The manager of the ward identified him as a Geordie and was happy to live with his language, as most other environments hadn't before. So now he's in a very appropriate environment. He's on less medication, and he has a clear-cut appropriate diagnosis of Lewy body dementia and being a Geordie, which I understand comes with a set of life expectations. So he is much better, but his life expectancy is relatively short. The risks of these episodes occurring again are certainly possible, and he will need ongoing support over the next number of years. But that was quite a good intervention. The problems for patients with Parkinson's disease when they're deteriorating are exemplified by this man. He has marked medication sensitivity with ongoing anxiety in relation to his dementia. So he's on mirtazapine, a cognitive enhancer, small doses of quetiapine, and levodopa. He's had huge change, which I think has contributed to his distress. But there's been major caregiver burden for his wife, who took a long time for him to agree for him to go into care. He's had his EPOA invoked, and he has some awareness of this at times, and this has caused distress for his family. So there's a need for ongoing involvement for him. So, at a rough pace, I'd like to move to the next slide and talk about one person with MND. This is a huge topic, but I thought I'd focus on one person who exemplifies many of the problems that we do have in managing patients with MND. As many of you will know, this is a very complex set of illnesses with variable presentations. There's a lot of research, and there are now emerging treatments for this. And there are a lot of clinical trials which are not necessarily available in New Zealand, but we can access them when we're not affected by worldwide pandemics. And this does complicate the management and treatment of some patients. However, there are very few life-prolonging treatments, but there are 2 or 3. One of them is MDT input, which is very important, and there are a couple of medications. One is riluzole, and there's the possibility of another one called edaverone. There are a number of clinical trials which are said to improve some of the symptoms, which was not the case up until a year or so ago. This is a patient that we were involved with a number of years ago. She was a young woman who received her diagnosis at age 32. She'd been married for a few years and presented with leg weakness. And this was progressive and eventually involved all limbs. She made the decision to have children after her diagnosis and had twins at age 34. Her father, who was in his early 60s, halfway through her illness, developed a bulbar palsy and had a very rapid decline and died in hospice care 2 years after diagnosis. He had a respiratory deterioration, he had aspiration, but had also been on NIV and had a PEG in situ. This young woman, around the time her father was deteriorating, developed an acute respiratory infection which necessitated a hospital admission. At that point, NIV was initiated. Normally these days, we would be monitoring people and can do it in the community in association with the respiratory team. She found that NIV did improve her fatigue and helped with her sleep and certainly allowed her to remain at home. But she was increasingly frail. She had extensive MND team involvement. Her house was modified Her husband and her mother were her major carers. Her mother came to care for her after her husband died. Her husband had also diabetes, which he struggled to manage with while she was alive. There was a huge external care package in addition to the support that the family gave. She managed her fatigue and breathlessness with support, an electric wheelchair, and she really didn't wish for any other interventions for her breathlessness. I think that in the last year of her life, she used 2 Panadol. But it was pretty clear that she was going to become dependent on NIV, and we had a lot of discussions about treatment withdrawal, which was clear was going to be necessary at some point. And she did make the decision that she wished to have it done. I think she'd been out to the movies and found it was really difficult. And then her children were about 5 years old. Her family was fairly settled, and she made the decision. So, in fact, we had to move fairly quickly. The NIV was withdrawn at home. She'd invited all her friends and family. Her GP, the hospice team, and the community MNT team were involved. Many of you will probably have been involved in similar situations. We used some intravenous medication and turned off the NIV machine, and she really died literally within minutes. So this was a long-term illness. She was unwell for about 7 years. Certainly the NIV probably prolonged her life by a good 18 months or so. There was significant carer burden. In this case, looking at fatigue, there was really good coordination of support with primary and secondary health care. The GP was very involved, primarily to support the family and the children, and we were able to withdraw treatment with planning and timing. We had to do it very quickly, but as soon as we knew that it was ready, we were able to go ahead and support her. But one would acknowledge that this would be a risky bereavement. Although family were ready, there was a great deal of sadness that it had happened, and there was a degree of finality that occurred in the room when she died, a great deal of sadness, but they have managed very well. So when we're talking about motor neurone disease and managing in the community, the interaction of all services is that we can look at medication a little bit. There's been a recent review of Riluzole, and this is what patients do focus on, so it is important to acknowledge that in some situations it does add to life expectancy, but whether it improves the quality of life, whether it slows down the progression of symptoms outside of MDT input and other interventions, is somewhat debatable because there's quite a variation. But using the interventions of NIV and PEG in appropriate patients can certainly improve quality of life. But the key issue, I think, with the involvement for patients is individualised care and using all the resources in the community. For NIV, for MND patients, what's really important these days is coordination. There's very active social networking. With the prospect of clinical trials, which are much more active than in the other neurodegenerative diseases we've talked about. We do encourage people to join the MND registry and access specialist services. And cognitive impairment, which was not apparent in our patients, is very important to manage. There are a number of interventions that can assess this, but I think good clinical judgment is really important and can really complicate the process of care. But I think that it's very important to emphasise the coordination can well be quite easy, provided you're willing to plan ahead. So that's the end of the talk.